Hey, thank you very much for joining this session. And as we like to do sessions for the regular general physicians, I mean every specialty can enjoy. So we've got a very stellar speaker panel this year. Again, Sagar, my dear friend who helped me during when I was the CMA chair to get. These kind of great speakers. So we reached out to him for the emergency medicine speakers, and we have got a great panel today. Dr. Upadhyay, Dr. Garg, and Dr. Daniels. And so the just wanted to let you know we just got back this morning, in fact, from China, from the AAPI tour, which was a very, very well attended tour. The people had fun. We had 6 hours of CME there also, and so that's a great thing. And I want you to also know that the convention. Um, is going to be on July 4th weekend, and we want you to go and register. The registration is open. It's going to be in Tampa, Florida, and Sagar Galwankar is the convener. Is the actually the chair, and Raghu is the convener. We're going to have a lot of CMEs which Tarak is working on. Great speakers, great plenary session on AI, and several parallel sessions, several CEO forum, and everything is there. The website is very easy, aapiconvention.org, apiconvention.org, or apicon2026.org. The program is there. Everything is there. And one little shout out to all of you. If you guys have any pharmaceutical or any other financial corporation or anybody who'd like to put a booth or do a product theater, please guide them our way. That'll be a great help. And we'll take it from there. Just guide them. It's going to be mutually beneficial. They'll get 2,000 attendees in front of them. And from our side, we'll also get some sponsorship. So, having said that, I will stop and let Dr. Garg take over and introduce Pia and the rest of the panel. Thank you so much.
Hello, everyone. My name is Nidhi Garg. I am the Director of Emergency Medicine Research slash Faculty Development Director at South Shore University Hospital. I'm also an Associate Professor of Emergency Medicine at Donald and Barbara Zucker School of Medicine at Hofstra with Northwell. And today I have the pleasure to present my topic of is GLP-1 a friend or a foe? Along with the two great speakers I have the pleasure to work with today, Dr. Shailendra Upadhyay, who is a chief of Division of Pediatric Cardiology and co-director of Children's Heart Center at Georgie Bachelor Endowed Chair in Pediatric Cardiology at Holtz Children's Hospital, Jackson Memorial Hospital, and he's going to talk to us about adult congenital heart disease. What's the primary cause? A care provider needs to know about that. And along with that, our another speaker, the third speaker, is Dr. Pia Daniel from SUNY Downstate, who's an assistant professor of emergency medicine and my longtime friend with director of emergency preparedness fellowship. She's going to talk about gun violence preparedness. It is our pleasure and honor to be here to in front of you and talk about our passion and the topics that we are really excited about.
Dr. Garg, can I interject just a couple of things here? First thing is that to obtain the CME, you will get the email probably 5 to 7 days after from eMed Events. You fill out the evaluation form and the CME will come in. Second thing is that Dr. Garg is moderator, but I think Dr. Daniel is going to leave after this, so we will ask questions before she leaves. That's what we are planning. Am I right, Dr. Garg and Dr. Pia?
Works for me.
Okay, great. And then I think so maybe we'll just do the same way, each speaker questions, and we can go from there.
Okay, sounds good.
Okay, and people can wait around. If you can wait around even after you're done, people have a lot of questions sometimes. They think afterwards. So please, if you are willing to stay around after your presentation, please do so. Thank you. I really appreciate everybody's help, and sorry to interject.
Yeah, no problem. I'm just gonna put it in the presenter mode. Give me a minute. It's just Zoom issues. So here we go. So today I'm going to start about with my topic with GLP-1s, a friend or foe.
Dr. Garg, again, I'm sorry. I think Dr. Pia wanted to go first. She's working today. Is it okay with you?
Yeah, absolutely.
I'm
Please.
so sorry again. We should have lined up the speaker's number. So
Sure, no problem. I'll stop sharing.
sorry for a little bit of disorganization from our side, guys, but we'll be okay.
Pia, you can go ahead and share your slides. I'll stop sharing.
All right. Are you guys able to see my slides and hear me okay?
Yes.
Yes.
Perfect. All right, with your permission, I'll get started.
Yes, go ahead.
Okay, wonderful. Thank you guys so much for inviting me. I'm always really happy to give lectures like this. I'm Dr. Pia Daniel. I'm an emergency medicine physician in New York City. And a couple of years ago, I was asked to chair the hospital's workplace violence committee. And so through that, we've been looking at different processes for workplace violence mitigation and response, both at our acute care facility, but also at all of our outpatient centers. So I'm going to focus this topic mostly on gun violence preparedness, but I'm going to have to talk a little bit about workplace violence and some things that you guys can hopefully start initiating in your departments. Again, I apologize, I have to leave for a clinical shift, but I will include my email. And as I go through this lecture, I'm going to sort of reference a lot of kind of simple actions that you guys can start implementing this week. I have a lot of templates for things, so I encourage you all to email me after this, especially if you think of something after I'm gone. If you want anything that I reference that you guys want to take a look at or that you want a copy of, I'm happy to give you guys digital versions of all the stuff that we've implemented. I have no relevant financial relationships to disclose for this. So what we're going to do is I'm going to quickly talk about de-escalation strategies for developing workplace violence incidents. So these are going to be sort of ways that you can help prepare your clinical area in the absence of a weapon. So just what are sort of the primary things that clinicians need to know about de-escalating? And then we'll talk more specifically about active shooter response and ways that we can help prevent and mitigate episodes of violence that include weapons. And then we'll talk specifically about healthcare specific issues, right? Because there's one thing if you're protecting yourself, but it's a different thing if you're in a clinical area and you've got, you know, patients and visitors and stuff to think about as well. So a couple of things. You guys have access to all these slides. And so a lot of these slides are actually the trainings that we do for our staff. So you guys are absolutely welcome to use these slides and adopt them for your own training. So everything that I've included in this, I am happy to share with you guys. I just want to start with, in general, you know, I know you guys all have different clinical settings. So kind of this slide kind of summarizes the most important things, and my summary slide will kind of go over into this in a little more detail. But I want you to sort of think about the different sites that you have, the different clinical areas. Again, for us, we're a huge campus. We've got, you know, an acute care hospital, but then we've got tons of outpatient sites. And so, you know, as I talk about this, everything that I'm saying, I kind of have to redo for each of my different sites. They all have really different parameters and needs. But in general, for each site, I make sure that everybody has a method of reporting incidents. So you really need to, before you even start approaching workplace violence mitigation strategies and trainings and active shooter, you need to get a sense of what are the incidents that your sites are experiencing and where are they happening. So for us, our reporting, you know, we have a lot of different methods that we make available for employees to report incidents, but you need to have some process where you are being able to capture and review incidents. So you can start to see, okay, which areas are my problem areas, and then we can focus our attention there. Making sure that you have really good connections with security. What is your security plan? Again, on my main campus, my university police are actually NYPD officers. So we have a lot of security on our main campus. But then when you look at our different satellite clinics, there's a lot less security. We might have less sort of NYPD presence. So the way that we're actually able to think about workplace violence and gun violence preparedness, it's actually going to be different at each of our sites, depending on the resources they have. And then in the, in the US, in the last couple of years, we've changed all of our overhead codes to be plain language. So there's a lot of debate about this for a while, as far as, notifying a facility or a site that there is something like an active shooter or a bomb threat or someone with a weapon. And there was this idea that they were using these codes, right? So they were saying code silver meant active shooter. But what turns out is that when staff doesn't really understand what the code means, then they can't really respond. And so there was a debate between, okay, how do we word this code so that everybody knows what's going on, but we don't cause panic? And really at the end of the day, and all the sort of the governing organizations agree that it's more important for people to understand there's an active shooter or a violent event going on. And that the risk of them not knowing is greater than the risk of causing panic by having an overhead code with plain language. So in general, when we're notifying our sites, we are using plain language, saying active shooter and the location. So there's been a lot of debate, and you'll have to sort of go see what makes most sense with your staff. But that was sort of the decision that the US is really beginning to adopt, is plain language code is better, understanding that it's going to cause panic, but again, people not knowing what's going on is more dangerous. And then setting up some system to do staff training. So I'll talk a little bit about workplace violence and de-escalation training. I'm not going to go into that for this lecture, but I included all those slides that you guys are welcome to adopt for your own trainings, doing practices with staff, de-escalating each other with different scenarios. So I have a few scenarios I'll share with you guys. And then doing trainings about weapons and active shooter, and identifying ways for staff to help manage those types of events. And then again, if you have multiple sites, then again, this is going to look a little bit different for different sites. So I just included a screen. This is the actual, this is a slide from the training that I do. We have two acute care facilities that are across the street from each other, but they're very, very different as far as their administration and the organization. So again, whenever I do this training, I make sure that whoever I'm training, that they understand all the ways to report incidences of violence, that they understand how to reach security. Different sites that we have different personal silent alerts. And so making sure that my staff understands, if you're in site A, this is how you can do a silent alert. If you're in site B, this is where they're located. Explaining to them what the overhead language is going to be, so they understand what they're hearing. And then also making sure they understand what the trainings are that are offered in each of these sites. So again, this is just an example. Essentially, you would take this slide and kind of adopt it based on the sites that you're going. So again, just really simple, like this is, very, very low resource interventions you can do to really just make sure that your staff understands that based on where they are working clinically, this is how they can report incidents, this is how they can reach security. And then if you have things like, personal alarms or other systems set up, letting them know what those look like. And I usually like to kind of list, let my staff know, okay, here are things that you guys can do right away, right? So this list is going to look different depending on what your institution or your clinical area looks like. But this is sort of a list of things that I always encourage my staff to do. I encourage them, attend a formal active shooter training, do de-escalation training, practicing a culture of safety, right? So understanding that, wearing proper identification, even though it feels rude, don't allow unauthorized entry to building. Don't hold doors open if it's an area where people need to have IDs to get in. And really just empowering all of your staff, so not just your attendings, but the clerks, the people who register, the nurses, the techs, empowering everybody to be accountable for the safety of your clinical environment. Really empowering every single person to be paying attention, reporting suspicious activity, and to be trained in de-escalation so that every single staff member understands how to de-escalate a situation. We have different workplace violence committees. We have them like for the emergency department, but also for our hospital. So I encourage staff to do that. So again, if you have a disaster committee, if you establish some sort of a workplace violence committee, encouraging staff to join that. And then again, you need to get the data for your clinical area to understand the scope of the problem. So you really need to sort of think of what is an efficient way for you to actually capture incidents so that you are able to really understand what types of violent activities are happening, where are they happening. All right, so I'm going to start by just talking a little bit about de-escalation. Again, this is sort of an hour training that I'm just going to quickly go through, but you guys will have the slides. And like I said, you guys are all welcome to take these and adopt and make it your own. But I always start active shooter training with just de-escalation training. And the first thing is making sure that my staff understands what workplace violence is. So the Joint Commission, which is sort of a governing body in the US a couple of years ago, really put an emphasis on healthcare organizations being accountable for assessing the risk or the impact of workplace violence on their campus. And so the first thing was that they wanted to kind of just broaden the scope of what we think about as workplace violence. So I know this is a gun violence lecture, so obviously, guns and weapons is obvious, but there's a lot of other kind of subtle things that do count as workplace violence. So the first thing when you're sort of training your staff on workplace violence is really just broadening the scope of what is appropriate and inappropriate behavior. And so make sure that if you've developed a system to capture, to let staff report incidents, that you're really encouraging them to report all these types of incidents so that you kind of understand that we're not just talking about when someone threatens your life physically with a gun, but there's a lot of different episodes of workplace violence. And even understanding that the type of workplace violence that you're going to encounter, it could be somebody coming onto your clinical site with the intention of do crime, but also just people can get into it, between patients and staff. And then also I've seen plenty of staff on staff fights that I've had to de-escalate. And then personal. So somebody has, something in their personal life and that person kind of comes in and has sort of a specific employee that they're targeting. So again, the idea is to just broaden everybody's understanding of what is workplace violence, what types of events are happening, and make sure that you understand the scope of it within your clinical area. So I think the easiest thing is to either do a survey or start an incident report system so that you're really able to capture what are the events that are happening so that you can start planning for them. And then when it comes to verbal de-escalation training, I have about 20 slides that I'm going to read through, but this one slide kind of summarizes all of them. So we usually do about an hour training with our staff where we really talk about, okay, here are the steps if somebody is agitated, de-escalating somebody is agitated. This, you should never do this if they have a weapon. So this doesn't really apply to guns, but if somebody is agitated, whether it's a patient, whether it's a coworker, whoever it is, these are kind of the key steps to helping manage this. And these are the types of things that, that you can take some time with your staff and you can practice this, you can practice scenarios, but also when you have real events and you've seen your staff have to de-escalate someone, like let's say that, a family member is really upset because they've been waiting in the waiting room for 2 hours and they're in pain and they feel like this clinic, they made an appointment, why aren't you seeing them on time? And they might come and be really, really upset. And it's a busy day. And so you want your staff to be able to kind of de-escalate this in a way that they feel comfortable and also in a way that you can then go back and give them feedback. So the key things that I say when I'm training staff on de-escalation of somebody who's upset, number one is being empathetic. And being empathetic does not mean you agree with them, right? So sometimes I'll be, somebody will be banging on the door saying, we've been waiting 20 minutes in the waiting room. Why haven't we been seen yet? And they're really upset. And so for me personally, I don't think waiting 20 minutes, in the waiting room for an outpatient visit is something to be that upset about. So it's not that I agree with how upset they are, but I can empathize. I can understand that, they probably did a lot to get to this clinic appointment today. They've probably been stressed about whatever ailment it is that they want to seek care for. And they don't know if it's something serious or not serious. So that 20 minutes was probably a really long time to them. So again, if somebody is really reacting and you feel like you don't agree with sort of the level of anger they're having, being empathetic doesn't mean you agree with them, but you're able to empathize and say, yes, I absolutely understand that you're been waiting a long time, you're concerned. Let's, here's what we can do to help deal with how upset you are. So again, I'm not agreeing with how they're reacting, but I'm able to kind of empathize and clarify the message. So sometimes people will come and they'll be yelling about a bunch of things, but really what they're upset about is the long wait time. But they might just start sort of saying many, many things they're upset about. And so it's really important for you to really try to clarify the message, show that you understand what they're saying. They may sort of when someone's fighting, they want someone to fight back with them. So they might sort of throw out challenging questions. I've gotten all sorts of things like racial slurs and all sorts of things when people are upset. You have to just put that aside. You need to ignore the challenging questions and go back to clarify the message. So whatever they're sort of saying, yelling at me, again, this is the situation where they don't have a weapon. I'm going to always sort of try to be empathetic. I'm going to say, listen, what it sounds like is that you're very upset that you've been waiting for 20 minutes. And I kind of just ignore all the other stuff that they were doing that was trying to rile me up. And then the other really important thing when you're training your staff, when you're kind of debriefing after an event, is make sure that your staff was being thoughtful of their own safety, right? So make sure the staff kept a good personal space distance. Make sure the staff, their tone, their volume, their physical gestures are not going to be are non-threatening, right? So you really want to take some time, again, either practice scenarios or when an event actually happens, debrief and talk to your staff about, okay, were you able to be empathetic with this person? It doesn't mean you have to agree with how mad they are, but you can still empathize with why they're mad. Were you able to kind of clarify their message, ignore challenging questions, didn't overreact, but really just focus on the thing that they needed? And did you keep yourself safe? So that's like sort of just a 2-minute summary of an hour-long training related to de-escalation, and that is only in the context of somebody doesn't have a weapon, right? You don't try to verbally de-escalate somebody with a gun. When somebody has a weapon, then we talk about retreating to a safe location. So what will be very helpful is actually going to your clinical area with your staff and kind of identifying which are the areas that are safest. So if somebody comes in with a weapon or a gun, for instance, which are the areas that that staff can bring patients, that you can hide, which doors lock from the inside versus the outside, which types of walls and infrastructure in your clinical area are going to be strong enough to prevent bullets versus not. So for instance, when I go to like a clinic and I'm showing the staff areas that they would hide, we identified this one area that most of the doors had, like there was a lot of windows, most of the walls were drywall, there wasn't really any concrete walls. And even though the door locked, we agreed that this isn't the best place because if somebody just shot into that area, there's so much glass, there's not really like any concrete walls and bullets would probably go through. We identified another area in their clinical space that actually has really good, strong concrete walls, has a door that locks from the inside and doesn't have windows. And so really just making sure that your staff understands that if something happens where somebody does have a weapon, have you thought through the best place for them to hide if they're not able to leave the area? Have you gone over the different exits and have you kind of trained them on encouraging, to bring patients and visitors along with you? So it's something really simple. It doesn't take any additional resources other than just somebody going to the site and talking to the staff about it. And again, this is something that people don't want to talk about. They don't want to think about. People get very anxious, even just thinking about somebody coming into their clinical space with a gun. But I promise by the end of just, a 20-minute kind of walk through and talking it through, people will tell me, like, I felt very anxious when we first started doing this, but I am glad I did it because even though I still feel anxious about something like a gun violent event happening in my clinic, I feel a little bit better that I at least have some idea of a plan, or I have some sense of what I would need to do. And before this training, I really, if that happened, I would have had no idea what to do. So the idea is to kind of empower your staff, make sure that they understand what is the safest areas, the safest paths to respond if somebody does come in with a weapon. And then, of course, contacting security. And then run, hide, fight is sort of the thing that's like trained for most people. And that applies to most settings, but we'll talk a little bit about how run, hide, fight might look different in a clinical setting. We want to think about patient. So the next few slides, I'm going to just go through very quickly. I'm not really going to talk on them, but these are essentially the slides that we use when we train our staff. So again, these slides, it just has to do with verbal de-escalation. This has nothing to do with disarming or active shooter. We always remind people that this training for the de-escalation is just if there's no weapons involved. But again, we usually schedule about an hour to kind of go over these slides. And then what we do is we kind of create this, I find it easy to kind of give people a score sheet. So I find that judging people on their ability to show empathy, how their tone of their and how they were speaking, their tone, their body language was used in such a way that didn't escalate the situation but de-escalated it, and then did they keep themselves safe? So these are kind of the four sort of rubric, four metrics that I'll use when we do these practice scenarios. So there's practice scenarios. Again, you can create your own scenarios based on the types of events that actually happen. But usually staff gets a lot out of practicing, and then with each scenario, then kind of debriefing and kind of going over saying, how did you do with the following things? So this is just a very quick kind of verbal de-escalation training that I just want you guys to have. But I'm going to move into the more general active shooter response strategy. So in general, when we're talking about active shooter or gun violence, there's not like one perfect demographic of an active shooter, but usually in most cases, active shooters don't plan on surviving the event. So that's why things like de-escalation isn't really going to work. A lot of times when somebody comes into a public site with a weapon, they are assuming that they will either commit suicide or they'll be shot down. So these are not people that you can really speak with. So your priority is going to be to protect yourself and your patient. I did speak a little bit about using plain language code. So this is sort of the primary thing that's taught to people, right? So the three main actions if there's an active shooter. So run if you can, hide if you're not able to hide, and if you are going to hide, you need to be prepared to fight if the intruder is able to get into your area. So the reason that we run, obviously, you just want to create distance between you and the shooter, especially if it's, overhead plain language and it includes the location. You would know your clinical space best. So you'll kind of know, like, okay, if there's somebody with a gun and they're in the waiting room and your office is in the back and there's a fire exit, that you can reach, that you don't have to go through the waiting room, then that's what you would do, right? So if there is a way that you're able to run and get out of the way, get out of the building, you want to do that. You don't want to bring anything with you, and you want to try to bring as many people as you can with you to the closest safe area. Now, if you're not able to do that, then hiding essentially gives time for the event to be over. Again, most active shooter events are over pretty quickly, but again, I think we can all think of like recent, in the last few years, events that ended up having a prolonged response. So hiding gives you time, and then understanding in your space the difference between covering and concealing, right? So concealing just means they physically can't see you, but cover is better because not only they can't see you, but it's potentially going to have something that will help prevent a bullet. So that's why it's really important to go to your clinical spaces and really identify in your space what would be the best place to conceal versus cover your staff, and really make sure that your staff understands the difference between these two things, and have practice runs where, they practice going and hiding in a place that will give them good cover. And then I usually tell people, if you're hiding, you need to have some plan if the intruder or if the active shooter gets into your area. So this, of course, is going to be a last resort. And usually the way we kind of describe it is, imagine that there's just three, staff members and you're hiding in a room and the door is locked, and you've got one, person who's entered the clinical area and they have a weapon. And if for some reason they're able to kind of break through that door. So the three of you now have some time, right? Because you're in a room, your door is locked. You know that the only way the intruder can get in is through that door. You know how the door is going to open. So you kind of know sort of the angle of that intruder's body. And so have a plan. So if the three of you have some sort of coordinated plan, if the intruder does enter your area, you're going to have a much better chance at winning that fight than if you don't have a coordinated response and you guys just react when they come in. And so what I'll do with the staff is we'll actually, practice 2 or 3 of them going into the room that they would hide. We'll practice having someone open the door, and we'll give them a moment and they'll organize some response. So they'll identify objects, like one person might have a stapler, another person might have another thing that could be used as a weapon. Person A is going to throw the objects at the active shooter's eye, face. Person 2 is going to throw it at their throat, and then person 3 is going to try to remove the weapon. So you can just imagine that, if something like that happened, those 3 people are going to have a better chance at disarming that person than if they had no plan at all. So again, part of it is going into the space, showing them the best places to hide, having them practice doing a coordinated response if they have to. And then what's really important is understanding that when law enforcement arrives, their job is to stop the active shooter. Their job is to not help victims or staff. So I always make sure that my staff understands that once law enforcement has arrived, you have two jobs as a staff member. I'd say the most important one is make sure that you are not that they don't confuse you for the active shooter. So make sure that your hands are up, that it doesn't look like you have a weapon, that you're following their orders. And your second job is just not get in their way, right? So if you have information to give them, like where the active shooter went, fine, you can share that with them. But in general, this is not a time to ask questions. You just are going to follow their instructions, and you're going to make sure that you are not confused as an active shooter. And then when we think about healthcare facility specific, right? So, depending on your clinical space, maybe it's a pediatric area, maybe it's a clinic where you do procedures, but there's other considerations we have to think about where just run, hide, and fight isn't really going to cut it as far as staff members being able to protect themselves and their patients. So so you want to practice kind of what does it look like evacuating patients in your area, right? So all of your areas are going to look different clinically. Like I said, I have to do this for a lot of different sites on my campus, and they all look very different. So the pediatric clinic, we're going to practice evacuating a little bit different than, an adult clinic. So practice, evacuating, practice, having fake patients and your staff kind of taking them through exits of safe passage. And then practice locking down units. And what does that look like when you have patients? So again, your clinical space is going to be very different. So look at your clinical space, think about where, just a typical day where you're seeing patients. So where is kind of everybody spread, and what is sort of the best way to help manage an event specifically in that space. And like we said before, really identifying the best kind of shelter in place settings. Other things that I usually encourage staff to do is to do things like stop the bleed training, especially for non-clinical staff. So like my clinics, yes, we have our MDs and we have our physicians and our training doctors and our nurses, but we have probably like more people in my clinic is probably going to be our tech, our clerk, admin people. So you have a lot of non-clinical people that might be involved in an active shooter response. So just having stop the bleed training, especially for non-clinical staff, and make sure that you have stop the bleed stuff like tourniquets, first aid kits readily available, especially in the spaces in your clinical area that aren't clinical. So think about your waiting room, think about just areas that you wouldn't have easy access to things like gauze and tourniquets. So think about having stop the bleed training and stop the bleed equipment ready. We talked about, using overhead codes. Again, a part of that is also so that patients and visitors understand what's going on. And again, really focusing on creating this culture of safety. And then understanding that you're going to know your site best, right? So if you've been working in your clinical area for X number of years and you've got, patients or visitors, they really might not know where the exits are, right? So as if you are running or if you're hiding, again, you want to understand that you're going to be surrounded by people who don't know the best path, who don't know that there's an emergency exit. So just be thoughtful and make sure when you're doing these trainings that you're encouraging staff to sort of be paying attention to all the people in the area. And then again, you're going to treat patients to the level of care that's possible given the situation. So again, if anybody works in an outpatient site where you do procedures, right? You want to think about, okay, if I'm in the middle of this type of procedure, what are ways I can do to, safely abort this procedure so that me and the patient can get to safety. And you want to try to protect your patients to the best of their ability. So again, some of these are a little bit more pertinent for inpatient units, but again, I think a lot of the outpatient areas, it's going to look different as far as your patients and how mobile they're going to be and how quickly you can have patients run. So it might be that you need to secure your patients and make sure that you're protecting them to the best of your ability. So when we think about the run, hide, fight, and we want to sort of adopt that for healthcare, then what I usually say is run, secure, preserve. So obviously, if you can run, you want to bring people with you. But if you're not able to run due to you don't have a safe exit, or you've got a patient that can't run with you and you don't want to abandon, then you want to think about securing the location immediately. So let's say you're in a procedure room, you're quickly wrapping up the procedure. What are things you can do in that room to secure it as best as possible? Locking the doors, turning off the lights, silencing machines, turning off cell phones, that kind of thing. And then again, if you have a patient and there's sort of ongoing patient care and you're hiding, then you want to do your best to preserve the life of the patient and yourself, right? So, again, if you're doing something like a procedure, if it's a patient that requires oxygen, or let's say it's an outpatient patient, but they're on a trach and they need a ventilator. So really, what are the ways that you can preserve the minimal steps you can do to preserve your patient's life, but at the same time, while you're hiding, while you're not sort of making your presence known to any perpetrators. So again, if you're hiding with a patient, again, thinking about, okay, where can we physically move so that we're not in the direction of the windows or the doors? And again, talking about different ways to, essentially empowering your staff to do what the best they can given the situation. It's really hard to sort of say in all situations you would do this, but just this general idea that, obviously we want to protect ourselves. We don't want to abandon our patients. So as much as we can to secure and preserve our patient's life while not putting ourselves in danger. And then, what's really hard to kind of talk about is just understanding, again, the scope of these events is going to be so different, right? So it's really hard to plan for everything, but understanding that it might be impossible to continue to care for a patient. And so it's really going to be a personal decision as far as, let's say that I'm in a clinic and I've got a bunch of patients that are non-ambulatory and there's an active shooter coming towards us. The decision for a staff member to stay and do everything they can to protect their patients versus to run versus to do something to protect their patients but still run themselves, it's going to be a personal decision in the moment. And so the idea is to encourage your staff to sort of think about it ahead of time so that if anything like this does happen, it's not the first time they're thinking about it. And then also, I always encourage staff, the best thing you can do in an event like this is to not become a victim yourself, right? So if there's something and you feel like it's really unsafe, but other people are doing it, you have to go with your own instincts. And so you and your colleagues, you may have totally different reactions, right? So you may feel like, okay, I know where the active shooter is. I think we can make it to that exit. I feel comfortable going. You can encourage your colleagues to come with you. You can encourage people to come with you, but if they're not coming and you really feel like that's the best thing for yourself, then you might have to, you have to accept that different people are going to react differently, and not everybody's going to have that same sense of what the best thing to do is. And then the other thing that I tell people is, be prepared to be locked down for a long time. Again, a lot of active shooter events are over pretty quickly, but the lockdown might be on for a while, depending on sort of how big your outpatient area is. Usually, for us, our university police, they won't really break the lockdown until they've really searched the entire building. So depending how big that building is, you might be locked down for a while, even though the actual active shooter event is over. So as far as kind of taking everything that I said and creating sort of next steps or actionable things you can do, starting tomorrow. So I'd say the first thing is identifying some method to capture workplace violence events. You really need to understand the scope of the issue in your clinical area, what types of events are happening, where are they happening, with what frequency. And you can do this through creating surveys, staff interviews. Again, I have a few versions of online surveys that I created for my staff. So you guys are welcome to reach out to me. I'm happy to give that to you as a template. But really, you need to first understand what is the scope of the issue. And then once you're able to get a sense of what types of workplace violence events are happening, then you can start addressing them and create mitigation plans, right? So, maybe one clinical area seems to have frequent events of type A, and another clinical area has frequent events of another type of workplace violence incident. So you might be doing different mitigation plans, right? But get your staff input on these plans, do a site walkthrough, make sure that you're identifying kind of just in the environment, what are safety precautions we can take in the environment, what are sort of dangerous things that could be used as weapons in the waiting room. And then, like we said before, really helping your staff identify areas that they can cover versus conceal themselves. What's the best place to shelter in place? And then just doing practices with them. So creating a workplace violence training program, doing de-escalation trainings with your staff, and then, doing practice scenaриos. Okay, imagine somebody walked in through this door and they have a gun. What would you guys do now? And again, it's a very anxiety-provoking scenario to think about and to practice. And usually staff feels hesitant and anxious at first because they don't want to think about it. But I promise every time I've done this, by the end of the training, whether it's a 2-hour formal training or just a quick 30-minute training, people always kind of come back after and they say, okay, I'm still really anxious about something like this happening, but I do feel a little bit more empowered that at least I have a sense of like step 1, 2, and 3 of what I would do. All right, so that concludes my training. I wanted to leave enough time for questions. And again, there's so many different pieces to this as far as like developing plans of how you're even identifying and flagging patients that are going to potentially be violent, especially like in our, like we have a psychiatric geriatric clinic. So, really, how are we actually identifying potential perpetrators of workplace violence? How are we flagging them, and how are we managing them both inpatient and outpatient in a way that we're not biasing against them, but keeping our staff safe? And then what kinds of things are you doing with the environment of your clinic to make your staff feel safe from weapons and gun violence? And again, depending on your resources, that might look like, having a weapons detector at all the entrances like we've done for our acute care facilities, but most of our clinics can't really do that. So then we just have more frequent security visits to those clinics. Certain clinics wanted to have bulletproof glass where people register, so we set that up. So really just looking at the environment of your different clinics, getting your staff input, and showing your staff that, okay, we're being thoughtful, we're thinking about weapons, we're thinking about gun violence, and we want to do the following things to make you guys feel safer. So with that,
Daniel. So I think we have some time for the questions. So we will
Please put your comments in the chat so we can ask questions that way, because you can't speak here, likely not.
So I see, Dr. Wasawada, you have a comment, ethical decision reminds you about New Orleans when some people were charged with abandoning the patients. What are your thoughts about that?
I mean, that's such a good point. And definitely when we were doing these trainings, like you have to be really thoughtful of how you're presenting like this idea of run, hide, fight, because I've definitely had like staff and administration being like, we have to really emphasize the difference between abandoning patients, but also, empowering people to do what they think is best for themselves, because we want as little victims at the end of this as possible. So it doesn't really help if all the doctors throw themselves in front of the gunfire and then we just have no doctors left to manage the victims. So it's really, really, really difficult. But again, it's just something to kind of think about. But it's really difficult. There's not like one right answer, really.
I think you raised a great point about private practice. For example, the smaller offices have actually lesser security than the hospital. And if, God forbid, something like that happens there, it creates a bigger dilemma, bigger responsibility on the physicians and the staff there.
I'm just wondering how much it would cost to create the reinforced room or something, because some, like in my new wing in my hospital, I was looking at the door, I said, this is very strong, and the hinges were like long hinges. And they said this is a safety room for us to hide if something happens. Like, whoa. This is
and I mean, again, the resources that we put towards this, again, it's gonna change based on the setting, right? So like in my actual acute care facility, we can put in a lot of dollars towards creating barriers, but in some of the outpatient clinics, they don't have the resources. So sometimes that might just look like us giving them door jammers or things like that. Like there's a lot of low resource things that you can do. So it's not about building bomb shelters in every clinic. But it's about, okay, let's look at our environment and let's think of like, here's our budget. What can we do with this budget? And even if you have a very small budget, just door jams and doing extra locks on doors, things like that are simple.
Do you have any particular characteristics that we should be careful, like for the shooters, or who can be more violent in outpatient setting?
So that's why I start by saying that you need to get a sense of what types of incidences you're having, right? So we spent like many, many months even just creating the process of how we even identify and flag potentially violent patients, right? So like right now, what it looks like is that like on rounds, I'll just sign out to, the next team. Oh, just so you know, the gentleman in cubicle 2, he threatened me 2 weeks ago. That's like kind of how we're doing those signups. So really identifying what are the types of violent workplace violence episodes that you're getting. How can we flag those types of patients? So there's not like one correct answer. It's really understanding what type of incidents are you having. And I've worked in different locations, and I feel like it's been different in different locations. So it's not like there's just one type of person that everybody has to be aware of. You need to look at your types of patients. Even like I said, like when I'm training my cardiology clinic versus my geriatric psych clinic, right? Those are very different patients that are going to those clinics, right? So they're going to have different sort of different types of workplace violence episodes.
Okay, Dr. Garg, I think we are short of time now, so we have to move on, and Dr. Pia has to go too, I think.
Yes. So please email me. Again, I'm happy to share anything you guys want with. If you want a template for the surveys we've done, if you want more information on like the process of how we're identifying, flagging, and managing violent patients. Again, this is like, I could spend like 5 days talking about this. And just to answer the one comment that was put in the chat box, thankfully, the question is, have I ever been in an active shooter situation? Thankfully, I have not. I do this training, and I hope that like with this training, I would, be empowered to act well, but, I don't know what my personal response would be. So I have not been an active shooter.
Thank you, Dr. Daniels.
Okay, thank you guys so much. Thanks for inviting me.
Thank you. We're going to move on to our next presentation. Dr. Upadhyay, you want to go as your second?
Thank you, Dr.
Yes.
I'm okay either ways. If you have any reason to go early, I'm absolutely fine with that too. Would you like me to go next?
Yes, please.
Okay, thank you. Well, good afternoon, everyone. Thank you so much for having me. Dr. Daniels gave an interesting topic on the gun violence, and I'm going to be prepared to talk about something that also makes people panic. Think of a pregnant lady who presents to the primary care and says, I was blue when I was born, and then had some open heart surgery done. That also will make you panic a bit. So we'll try and learn a little bit about adult congenital heart disease. Of course, it's an enormous topic with each section having its own specific challenges. We'll try and summarize that into the most complex form and what usual primary care or internal medicine issues will encounter in these category of patients. So thank you again. So I'm Shailendra Upadhyay, Chief of Pediatric Cardiology and Adult Congenital Program at University of Miami and Holt Children's Hospital. My background is both internal medicine and pediatrics, and I also do arrhythmia management across the age spectrum. So let me start by sharing my screen. Okay, can you see my screen?
Yes, we can see it.
Okay, perfect. So I have no disclosures. And these are the topics we're going to look at. We'll look and understand as to why adolescent and adult congenital heart disease is a growing problem. We'll try to identify ACHD as to how complex it is, whether it's a mild complexity, high complexity, or great complexity, and who should be managing different complexities of this condition. And then we'll talk about implementing proper follow-up care in ACHD patients as to who should be taking care of these patients. We'll also identify long-term cardiac issues very briefly, and then we'll go over long-term internal medicine issues, which will be the major bulk of our presentation today. So we'll start with the ACHD being recognized as a growing problem. What is the most common birth defect? Believe it or not, it's congenital heart disease. About 1% of all live births are born with congenital heart disease. So if you're sitting in a room full of 100 people, one of them has congenital heart disease. So it's very common. And the good news with adult congenital heart disease is you can really do whatever you want in your life, despite the complexity that may come with it. You can be a movie star, you can be Backstreet Boys, a singer, you can be an Olympic skateboard champion, Shawn Michaels, you can be Mr. Tal, who's a cricketer in India. Madhubala, you may know that she had a congenital heart disease that she died from. And then Vipasa Basu's daughter has congenital heart disease, and many more. You can be a mixed martial fighter. Really anything you would like to do nowadays you can do despite having complex congenital heart disease due to advances in treatment. Moving on to this next slide, the population is rising, because nearly all of them now live up to being adults. Nearly 2 million people are estimated to be living among us in this day and age within the USA, and the population keeps rising by at least adding 20 to 40,000 patients each year. So one of the fastest growing areas of adult cardiology is adult congenital heart disease. In 1960s, we had more children with congenital heart disease than adults. In 1985, the numbers became balanced, and now we have more adults living with congenital heart disease in the US than children. We'll look at the classification of adult congenital heart disease. So it has been categorized, just for the simplicity of who should be taking care of these patients, into mild complexity, moderate complexity, and severe or great complexity. Mild complexity means you have a single heart valve disease, or you had a single hole in the heart that was closed or that is repaired, things such as bicuspid aortic valves or repaired atrial septal defects. The primum, not the primum, but the secundum, or the usual type of atrial septal defects. Then you have moderate complexity patients such as tetralogy of Fallot, or you have AV canal defect, Epstein anomaly. Those would fall in the moderate complexity category. And then you have great complexity, where you have patients who are born with single ventricles who have undergone Fontan circulation, which is something we'll look at in the next few slides. And what's the importance of this classification that's clinically relevant is if you have mild complexity, those patients can be seen by general adult cardiology because they get adequate training to take care of patients, for instance, such as with bicuspid aortic valves. On the other hand, moderate complexity patients must be followed and taken care of by an adult congenital heart disease specialist, along with a general adult cardiologist. When you have great complexity, the bulk of the cardiac care must lie with the patient in an institution where the physician has expertise in adult congenital heart disease. Talking about implementing proper follow-up care, and why do we want to make sure that these patients are regularly followed? There's loss of follow-up. When they are in the pediatric age group, because parents are bringing them to the physician appointments and stuff, everyone gets seen. But as they get to the teenage years or beyond, they feel like they're either cured or they don't require an ongoing follow-up. And there's nearly a 50% loss to follow-up in these patients. And when they present eventually, they're very sick if they had any moderate or great complexity congenital heart disease. And many reasons why that happens, just hand off from the pediatrics to the internal medicine world of these patients, maturity issues, they have psychosocial issues. It requires a lot of coordination, transitioning care between pediatric and adult systems. There can be medical competency issues because many of these patients have developmental delays or neurological disorders or genetic syndromes that may make them medically incompetent. And why should we make sure these patients are followed at an adult congenital heart disease center? Because there's a significant mortality benefit. Now, let's look at long-term cardiac issues in congenital heart disease patients. Any patient that I see, I try and address 4 things in them, whether they have heart failure. They can have valvular heart disease, they can have myocardial fibrosis, scars from multiple prior surgeries, cardiopulmonary bypass. They can have arrhythmias or rhythm issues, very, very common. Nearly 50% will have, some kind of arrhythmia by 50 years of age in moderate grade complexity congenital heart disease. They can have bradyarrhythmias, they can have tachyarrhythmias, sudden cardiac death risks, heart block, needing pacemakers, device therapies, and ablation procedures. They may have residual defects or shunts. They may have a VSD that was left, or even after the repairs, many patients such as tetralogy of Fallot will be left with pulmonary valve insufficiency and many things along those lines. And of course, pulmonary hypertension and Eisenmenger syndrome. And Eisenmenger syndrome is rare to see in the US except for patients who come here as immigrants, although there are certain scenarios you will encounter patients with Eisenmenger syndrome. We'll look at, example of a great complexity congenital heart disease. And the reason why I'm presenting this is not because it's the most common, but because this is one of the most complex or severe forms of congenital heart disease that we see in the repaired age group. And if we understand and learn about these category of patients and the internal medicine issues they will encounter, it's much easier to think of the other ones. And in my opinion, I think any patient with the congenital heart disease, which is not simple, that you ever encounter in your career, approach them system-wise from head to toe and think of it like a multi-system disease rather than a primary cardiac diagnosis. So can you live if you're born with a single ventricle? It's interesting. We're talking about the emergency rooms. One of our patients who had single ventricle repair with a Fontan circulation went to an emergency room, and he told them he only has one ventricle, and people laughed at him because they did not know that patients with single ventricles can survive. So you absolutely can survive with a single ventricle. And then about 6 or 7 disease conditions or anatomic defects you're born with that will require a single ventricle palliation. And these are certain names I'm talking about: hypoplastic left heart syndrome, tricuspid atresia, double-inlet left ventricle, pulmonary atresia, intact ventricular septum, double outlet right ventricle with hypoplastic left ventricle, unbalanced AV canals, and numerous categories of heterotaxy syndromes. It all seems like a medical jargon, but I'll share what these basically represent. So in a usual heart, the way I think of it is a combination of 2 pumps. There's a pump on the right, which receives blue blood from the body, and then it pumps it out to the lungs to get oxygenated. Then after receiving oxygen, the left heart is going to pump the blood out to the body. So there are 2 pumps, one on the right pumping blue blood to the lungs. There's another pump on the left pumping oxygenated blood to the body. And when you have a single ventricle condition, one other thing before I move on to that is, if you all are familiar with the intracardiac pressures. If you drop a central line in somebody's superior vena cava, the mean pressure is like 5 to 8. And mean pulmonary artery pressure is like 12 to 15. When you have a single ventricle condition, you are born with one of the pumps, either the right or the left, that's deficient or too weak to sustain pushing blood either to the lungs or to the body. And those patients, the way we repair them is with what is referred to as the Fontan circulation. The idea here is you take all the blue blood from the upper half and the lower half of the body, or the superior or the inferior vena cava, connected directly to the lung arteries or the pulmonary arteries. And this way, all the blue blood will go to the lungs without a pump. Once it gets oxygenated, that pump is that is all going to return to the left heart with oxygenated blood. And the single ventricle or the pump that you have, you're going to use that to pump blood to the body. So this way, you have established what we refer to as a Fontan circulation: all the blue blood going to the lungs without a pump, and all the oxygenated blood returning from the lungs going to the body through the single ventricle or single functional ventricle that you have. Now, there are certain consequences. If you look at the pressures, in a right heart, like I said previously, your CVP is about 5 to 8, whereas in a Fontan circulation, because the superior vena cava and inferior vena cava are connected directly to the lung arteries, your pressure here is going to be your mean pulmonary artery pressure, which is 12 to 15. And if you think of the organs in the body, all the venous connections from the liver, from the kidneys, and lower down in your legs, they usually see a CVP of 5 to 8 or venous pressures of 5 to 8, but now they all are going to see a higher venous pressures of 12 to 15. And over time, you're likely to develop congestion in the liver, in the kidneys, varicose veins, and high venous pressure. So kind of think of it like a right heart failure state with elevated pressures in the right side of your body. So now, keeping that thing in mind, we will address long-term internal medicine issues in adult congenital heart disease population. The way I think of internal medicine issues is approaching it from head to toe. I think of a Fontan circulation or any moderate or great complexity congenital heart disease as a multi-system disease. That way, you're likely to address pretty much all of their issues from head to toe. So we will look into the neurological issues in these patients, neurodevelopmental and genetic issues. Then we look at endocrine issues. We look at pulmonary issues. We'll look at liver GI, hematopoietic and immune system issues, kidney issues, genitourinary issues, rheumatological and vascular issues. And something that I don't have on the table here is just know that these patients, can also become pregnant, and that follows a different set of issues altogether, worsening their pre-existing hemodynamic state. Now, moving on to the neurodevelopmental and genetic issues, they're very common. So many reasons, right? Even before you're born, you can have abnormal blood flow to your brain that leads to malformed brain development. You can have, in a post-operative period, you may have hypoxia, you may have cyanosis, you may undergo open heart surgeries that requires cardiopulmonary bypass and hypothermia, and all of these things along with the worries as you get older that I have a heart condition, that I'm going to have long-term issues, leads to further problems over the years. And again, the degree of neurocognitive functioning in the congenital heart disease patients depends on the degree or the complexity of their congenital heart defect as well, and whether they have associated syndromes. So they have deficits in executive functioning, intellectual functioning. They have issues with visual spatial abilities and verbal fluency. In other older age group of patients, adolescents and adult congenital patients, we see a lot of ADHD. They perceive their quality of life to be much worse than their other counterparts. They may have a lot of somatic symptoms, anxiety, depression. Also, they may have issues with sustaining jobs and financial strains that come with it. Depression is extremely common, nearly 1/3 of the patients, and about 1/3 of the patients also get diagnosed with a formal psychiatric disorder. And to remain a center that cares for adults with congenital heart disease, one of the requirements is to make sure they have on-site availability of psychological and psychiatry support. What about cerebrovascular accidents and cerebral abscesses? They are at increased risk for many reasons. That oftentimes there's cyanosis, which causes polycythemia. Just know that when you're cyanotic and polycythemic, you tend to develop iron deficiency, and the iron deficient cells are very stiff, and they tend to kind of occlude the blood vessels, presenting with hyperviscosity-like problems, and they also increase your risk of developing brain abscesses. And of course, atrial arrhythmias, as we know, is very common in this age group and the population. And if they have atrial arrhythmia similar to atrial fibrillation, they can develop strokes related to clot formations in the heart. Cerebral abscesses that we talked about with cyanosis, and you may also have residual shunts from right to left that can lead to strokes in these patients. Genetic syndromes are very common. There are some that are really rather common, in patients who have DiGeorge syndrome or 22q11 deletion syndrome, also known as velocardiofacial syndrome, can manifest with cardiac findings of what we call conotruncal abnormalities, such as tetralogy of Fallot, interrupted aortic arch, truncus arteriosus. Down syndrome, as we know, it's a board question that is associated with common AV canal or atrioventricular canal defects. You have Turner syndrome, which may be associated with coarctation of aorta. Noonan syndrome can be associated with pulmonary valve stenosis. And just know that the adult congenital heart disease patients can benefit from routine assessment of their brain health due to all of these concerns. Moving further to endocrinopathies, it's also very common, including thyroid disease, including metabolic syndromes. And if you look at the prevalence of metabolic syndrome in ACHD population, it's much higher than the general population, nearly 2 to 3 times higher. And people have also looked at studies. There's certain types of diagnosis where it's more common than the other types of diagnosis, such as the tetralogy of Fallot. It's more common than some of the other forms. So think of metabolic syndrome, and often this happens because previously physicians didn't know whether they can exercise or not, whether they should participate in sports as their peers and counterparts, which we know that for most parts they can. And when we perform the counseling towards healthy living habits, we have to keep all these things in view. What about pulmonary issues? Quite common. It can happen due to numerous scenarios, such as things that lead to increased vascular remodeling. For instance, if you have atrial or ventricular septal defects, they can cause excessive blood flow to the lungs and the pulmonary arteries, which leads to vascular remodeling and can also lead to pulmonary hypertension over time. You can also have issues with hypoperfusion, less blood flow to the lungs. Things seen in conditions such as pulmonary atresia, tetralogy of Fallot, which can cause issues related to obstruction or restriction. It also happens from open heart surgeries. You have fibrosis and chest wall that's not as compliant. All those things can worsen obstruction restriction in this age group or patient population. Common findings when we do PFT analysis in these patients, they tend to have a decreased functional vital capacity or total lung capacity. They have low FEV1, FVC, elevated residual volume. So in other words, there's increased risk of obstruction and restriction. They may have a poor lung compliance from stiff lungs from pulmonary overcirculation. They have a decreased diffusion capacity. And in general, most of the things that you would think of in obstruction and restriction that come in patients are quite common in the ACHD population, depending on the complexity. This is just a slide on the frequency of PFD abnormalities and some common forms of adult congenital. Nearly 80% of the patients with tetralogy of Fallot will have PFD abnormalities. In patients with atrial septal defect that wasn't repaired for a long time, about 50% will have PFD abnormalities, and also patients with ventricular septal defects who are not repaired for a long time would demonstrate PFD abnormalities. And why do we care? There's decreased exercise tolerance, and you have impaired aerobic capacity. You also have increased risk of pulmonary infections in this population. And there's increased perioperative risk, whether it's a cardiac or non-cardiac surgery, their risks are higher. And it's not just their baseline that may be impacted because they have impaired lung functions. If they get sick with, say, for example, pneumonia or COVID, they have limited reserve, and they can really fall or tip off the curve to get very, very sick due to pre-existing lung issues. They can also have AV malformations in the lungs. So when we do the Fontan circulation repair, it's done in stages. First, you connect the superior vena cava only to the lungs, and subsequently you also join the inferior vena cava. But if you have a situation where only superior vena cava is connected directly to the pulmonary arteries, it lacks what we call the hepatic factor. So there's this theoretical factor that comes from the liver and travels through the IVC to the lung tissue that prevents formation of AVMs. If you leave someone with the SVC only connected to the pulmonary arteries, it can referred to as a Glenn operation. They will develop AV malformations in the lung rather quickly. And something similar that you encounter, which can be attributed to the hepatic factor, is that patients who have advanced cirrhosis, they develop AVMs in the lungs as well, the hepatopulmonary syndrome that you see in patients with cirrhosis. And that's where the idea of the hepatic factor causing AVMs in the lungs came from in patients with Glenn operation. Plastic bronchitis. So as I shared, that these patients tend to run high CVPs in 12 to 15. And if you have a poorly functioning ventricle, you have insufficiency of that single atrioventricular valve that you have, it's going to cause more increase in your venous pressures. And when you have increased pressures in your venous system, it causes increased pressures in your lymphatic system as well. And you start leaking proteins in your bronchial tree. And oftentimes this can be coughed out as CAS of your bronchial tree, a condition called plastic bronchitis, often seen in patients with failing Fontan circulation. The diagnosis of pulmonary embolism can also be challenging. So if you ever encounter a patient with Fontan circulation or any other form of complex congenital heart disease, you're worried about pulmonary embolism, please reach out to an adult congenital heart disease specialist and radiology colleagues to guide you in terms of right ways of injecting contrast, because in a Fontan patient, if you inject a contrast in the right arm to detect pulmonary embolism, it preferentially will go to the right lung through the SVC, and you will see a big filling defect in the IVC. When there may be no pulmonary embolism, you might mislabel the patient as having pulmonary embolism. And the caveat is, about 17 to 20% of patients who have Fontan circulation can have true pulmonary embolism as well, but it's a diagnostic challenge, and therefore you must involve an adult congenital heart disease specialist to guide you through the right type of testing when you are evaluating these patients. What about liver and GI? So just like you have elevated venous pressures that can be manifested in your lungs, you have similar elevation in your pressures being manifested in your liver. And as in regular adult cardiology and heart failure patients, we're recognizing the cardiohepatic or the cardioliver syndrome. Similar things can be encountered in patients with congenital heart disease. Aortic valve issues, mitral valve issues, elevated atrial pressures, pulmonary artery pressures, all of these things can lead to liver congestion. As you saw in the Fontan circulation, their liver is subjected to a much higher venous pressure, ranging between 12 and 15, which gets even worse if it's a Fontan circulation that's failing. You will develop liver congestion, cirrhosis, and then even hepatocellular carcinoma over time. So about 80% of Fontan patients will have liver abnormalities. So we do annual blood work in these patients involving their LFTs, kidney functions. They may also have abnormalities in transaminases if they have ongoing volume overload or heart failure concerns, but oftentimes at baseline they would be normal. If they have elevated volume situation, they may have an elevated bilirubin. And almost all of the patients with font-time circulation will have an elevated gamma GT. Alk phos is often not elevated, but if they have worsening heart failure symptoms and congestion and volume overload, they may also have an elevated alk phos. So in general, when you see LFTs in font-time circulation, the most common abnormality will be an elevated gamma GT. What about hepatocellular carcinoma? It's overall, it's much higher than the general population. It's more likely to be present if you also have associated hepatitis B or C. Just know that you have to do a regular follow-up aside from the liver function test, looking at the alpha-fetoprotein, which offers about 60% sensitivity. And you may want to do ultrasound, if these values are elevated in the liver, and look for elastography every so often, and also do advanced MRI if you have any concerns for ongoing hepatocellular carcinoma or elevated risk for hepatocellular carcinoma. Once you do a resection, the recurrence rates are high because the primary problem in the heart, which was there, has not been taken away. That's why oftentimes these patients will require a dual organ transplant of the heart and the liver. It's also very common for these patients to have paragangliomas and also pheochromocytoma. And there's some hypothesis that cyanosis triggers development of these findings in ACHD patients. Protein-losing enteropathy. So easiest way to think of protein-losing enteropathy is just like you had plastic bronchitis. High venous pressures lead to leakage of proteins in your gut, which can lead to diarrhea and protein loss, and you can develop what is referred to as a protein-losing enteropathy. And again, once you have that in the setting of font-time circulation, it carries a poor prognosis, will mean that they're heading towards needing a transplant. What about cholecystitis? Again, it's very common in patients who have cyanosis and polycythemia. So increased cell breakdown leads to development of gallstones and need for surgery. Now, kidney issues. Again, kidney issues are very common. As you know, there'll be elevated CVP that causes proteinuria. It's very, very common. Up to 40% of the patients in adult congenital heart disease category will have mild, 9% will have moderate, and up to 72% of patients who have Eisenmenger syndrome have a decreased GFR and associated chronic kidney disease. Again, depending on the type of the congenital heart disease, you have more or less degrees of kidney problems. It's a good idea to assess their kidney function at least once a year. Cardiorenal syndrome in adult congenital heart disease. So this is one of the hot topics in the heart failure group of patients. And the patients with congenital heart disease can have kidney problems related to a systemic right ventricular failure, meaning patients such as Sertoli Fallot, whose RVs don't work too well, or you may have subpulmonary right ventricular failure. Excuse me, I misspoke. Subpulmonary would be patients who have Sertoli Fallot or Epstein anomaly, whereas systemic RV failure would be patients where your right ventricle is pumping blood to the body, such as L transposition of the great arteries, or these are the patients who have D transposition of the great arteries who have been repaired with a mustard or a sending operation. Then you, of course, you have font-time circulation, where it's a single ventricular failure. All of these things causing one way or the other, either activation of the renin-angiotensin system or increased venous pressures causing renal dysfunction in these group of patients. Renal dysfunction and mortality. So 3 times higher mortality if you have associated renal dysfunction. So renal dysfunction may not be a primary problem with the kidney, but overall poor health of the cardiovascular system that's causing renal dysfunction. What about genitourinary issues? Of course, it's quite common, and you should ask these patients whether they have these things going on. As much as 40% of the patients will have some kind of genitourinary dysfunction, including erectile dysfunction. It's more common if they're taking beta blockers for either heart failure management or for arrhythmias. The There always comes a question whether these patients are candidate for using medications such as sildenafil for erectile dysfunction. And they can certainly be used in patients with Fontan circulation. There are also shown benefits in terms of improving the functional capacity really by relieving the pulmonary vascular resistance. What about hematopoietic and immunological issues? So these are also quite common. We talked about anemia, which may be present in as much as 13% of the adult congenital heart disease patients. It's most common in patients with the congenitally corrected transposition of the great arteries or Epstein anomaly. But you should be on the lookout for this in pretty much every category of patients. It's also iron deficiency is also common in patients who have polycythemia, and while they may have normal levels of hemoglobin, they're iron deficient, and iron deficient cells are stiffer and they cause their issues. Mortality is common in when you have anemia associated with congenital heart disease. Again, it may speak for conditions such as worsening heart failure and dilution and things like that. So you want to make sure that you look for anemia and replace iron or other nutrients that may be deficient, triggering anemia in this population. And what about cyanosis, blood viscosity, and iron deficiency? So we said iron deficiency is common. And if you're iron deficient, then it can affect stiffer cells and cause issues such as stroke or cerebral abscesses. It can also trigger hyperviscosity, but whenever you have hyperviscosity, the phlebotomy is almost never the right answer unless you're having acute hyperviscosity related syndromes, and watch out for the CVA in patients who have iron deficiency. What about malignancy in adult congenital heart disease? It's quite common as well, almost twice as common as the general population. And numerous factors may be contributing to that. Radiation exposure, because these patients undergo multiple cardiac catheterizations, electrophysiology procedures, and then you have Fontan subtypes with elevated pressures in the liver, increases the risk of hepatocellular carcinoma. Of course, if you have added triggers to developing malignancies such as alcohol exposure, smoking, metabolic syndromes, and genetic syndromes such as ALL may be common in patients with Down syndrome, increases their risk of malignancy. And what about immune deficiency? So there's a group of conditions referred to as the heterotaxy syndrome, which can be thought of as bilateral right-sidedness or bilateral left-sidedness. So conditions where you have bilateral right-sidedness, you have absent spleen, because spleen is a left-sided organ referred to as asplenia. And then if you have bilateral left-sidedness, you have multiple spleens or splenios, and it's referred to as a polysplenia syndrome. While both of these may have absent or multiple spleens, they tend to have splenic abnormalities, and they're likely to be at a higher risk of infection from encapsulated organisms. Patients who have DiGeorge syndrome have absent thymus, and thymus helps in growth of the T cell immunity. So these patients are at risk for some viral infections or fungal infections and things like that, particularly if they get sick. What about hematological and vascular issues? So if you're polycythemic or if you have increased cell turnover, you're at risk of developing gout. And this is a wonderful quote from Dr. Somerville published in the British Heart Journal in the 1960s, where she talks about gout in a cyanotic congenital heart disease patients. So if a patient who has congenital heart disease, who is cyanotic, who presents to your emergency room, and if they have a joint that looks red and hot, obviously you should be thinking about septic arthritis, but keep in mind that this could well be a manifestation of acute gout, and think and look for it and treat it that way. What about venous health? Because of the increased venous pressures, varicose veins are very common. As much as 40% of the patients, 40 to 50% of the patients will have major vein issues as they are older. It's not just from increased venous pressures. Just know that if they've had multiple cardiac catheterizations, the femoral veins may be occluded, and they may have collaterals that can manifest with DVT in the lower extremities as well. So in summary, the adult congenital heart disease population is on the rise, with nearly 2 million living in the US. They must be referred to an ACHD center as it improves mortality. These patients can have multiple internal medicine issues, and if you address them from head to toe, you're more than likely to pick up issues that may be lingering in these patients. Often we need a multidisciplinary approach in these patients, such as teaming up with an adult congenital heart disease specialist, a heart failure specialist, an arrhythmia specialist, and liver, pulmonary, GI specialists, among others. These are some of the references. Thank you. That's all I have with the presentation. I'm happy to take on any questions.
Thank you, Dr. Upadhyay. That was a great presentation. I personally learned a lot. If the group has any questions, please feel free to write in the chat. I have a question actually. If say we have a patient in a remote area and the emergency room, for example, is not very certain, as you were saying, like they come and there's a lot of like panic if you're not familiar with these situations and these people are living longer. What's your recommendation? Should like people usually like call where like patient got the first treatment like we do for the transplant patients, and are the physicians willing to like work with the physician at the site, or you just consider transfer most of the time?
Absolutely. So first and foremost, do not panic. And the second is do a good physical exam. There's so much you can pick with a good physical exam. It's unbelievable. So I'll give you an example. When I was a fellow, I'm not going to name the program. There was a patient who was repaired in Malaysia, had a tetralogy fellow, came there. She was a student in a university, was experiencing some chest pain, came to the emergency room. They get an EKG and they freak out. It's a very wide, complex, sinus rhythm, but very wide complexes. They get a pulse. They can't get a pulse in the right arm, can't get a blood pressure, but the patient is sitting, walking, and talking. All that they had to do was check the pulse in the other arm because she was a tetralogy fellow who had a repair with a lactosic shunt. That's why you lose the pulse in one arm. Which is kind of a normal finding in someone like this. So do a good physical exam, check pulses in both arms, all four extremities, get saturations if you can, get a good saturation in one arm, make sure you check it in the other arm. And assess the patient clinically, like despite no pulse and stuff, make sure that the patient is walking, talking, and breathing fine. They're probably not that sick, so you're missing something. So aside from trying to get most of the clinical information from the previous program, wherever they may have been followed, just go with your ABCs, do a good physical exam, and approach it that way. Just know that if you always look for the other arm, other limb for checking their pulses, blood pressure, vital signs, if it's not adequate in one.
Thank you. That's very informative. So in the interest of time, we will move on to the next presentation, which is my presentation. So I'm happy to discuss a topic that I'm actually very passionate about, given how the world is. There's obesity is a pandemic, and there's a lot of diabetic diseases which we see on an everyday basis. And I'm trying to make this presentation more like friendly to all the specialties, so it is not just focused on one specialty. So today we're going to discuss how GLP-1s have changed our world overall as a physician and how we can navigate it together. And we will also talk about the presentations in the ED. This stems from my to begin with, I do not have any conflict of interest or no disclosures to make for this presentation. It entirely is a passion and a choice because of my work with heart failure, but I don't have any conflicts or disclosures here. The learning objectives are the GLP-1 literature review and some of the clinical presentations of GLP-1, along with the management changes to our clinical practice, as I mentioned before. So GLP-1s are the new breakthrough in the medicine, and they are rapidly infiltrated the market, and more patients you are seeing in everyday practice who are on these drugs. I'm not gonna talk about like what these drugs are to bore you, but they are glucagon-like peptide 1 receptor agonists, which are a class of medications that actually mimic a natural hormone, which manages type 1 diabetes and is also approved for management of obesities. How it works is typically stimulates the insulin release, increases the insulin sensitivity, slows the digestion, and then reduces the appetite, which further promotes the weight loss and also improves the blood control. Some of the very famous drugs that you may have heard are Ozempic and Wegovy. It is released from the K cells in the gut cells, and I also believe that some of the secretion occurs from the pancreas, and it works on our brain by decreasing the appetite. So it has a central action as well. And as you eat the food, you feel like more full, increase satiety, and increase expenditure. So you definitely, it has a portion control. So if you are used to of eating like X amount of food, you are definitely gonna eat like 1/3 or 1/2, which is very similar to like the action of like gastric bypass for the bariatric surgery by decreased portion control. Then there's a blood sugar management. They increase your trigger the pancreas to release more insulin, and there is more insulin sensitivity, and it manages your glucose level, and it also inhibits glucagon. The next action, how it works, is about delayed stomach emptying. It decreases the transit time of the food. So some people also call it gastroparesis, or it's called clinical gastroparesis phase, where it's your movement of the gut is slower than usual. And it's not just like stomach, it's the overall gut as well. The fourth action that it works is the cardiovascular and metabolic health. So beyond the glycemic control, it is also proposed that these medications can decrease their cardiovascular risk, and it's multifactorial because, as you know, like weight is related to the blood pressure. So if you lower the weight, you lower the blood pressure. Obesity is also inflammation state, so it reduces the inflammation and increases the fat metabolism, and hence decreases the overall vascular changes that affect the multiple organs associated with multiple cardiovascular risk factors, which are associated with like hypertension, diabetes, high cholesterol, which are actually the precursor to multiple cardiovascular diseases like MIs, stroke, namely the large one. So the common GLP-1 medications that are available in the market are three drug products at semaglutide, which is sold under Ozempic, Rybelsus, and Wegovy. So Ozempic and Wegovy are the most famous one, and they're typically approved for type 2 diabetes, but Wegovy was FDA approved for weight loss as well. Then there's a second one, tirzepatide, which is also sold under the name Mounjaro and Zepbound. Mounjaro is typically prescribed for type 2 diabetes, and Zepbound has been FDA approved for weight loss. However, the salt is pretty much the same. Liraglutide is Victoza and Saxenda, which is used for diabetes and weight management as well. And these are some of the pictures of how these shots look like. If somebody has not seen them, they are basically a pen. They are single-use pens, multi-use pens, and we're going to go over that. Before we get into that, I just want to give you the timeline of the research and how this, landmark drug has entered the medical world, which has changed and revolutionized not only the diabetes care, but also the cardiovascular health in many, many ways. So in 1932, the incretin, which is a hormone, which is the fundamental action, which is released from the GLP-1, was observed. And then until 1980, so nearly 50 years, that receptor was not identified. The GLP-1, the receptor was identified, and another 25 years later, the first GLP-1 beta was approved for the diabetes. And then it took another 11 years for another drug to come to the obesity market. And it's only until 2017 when Ozempic was approved for type 2 diabetes. And then from there, the consumption and the infiltration in the market and the trials have just skyrocketed. So what's the difference in all these drugs? So most of the drugs are GLP-1, which is glucagon-like peptide 1 receptor agonist. However, the tirzepatide is combination, which is GLP-1 and GIP-1, which is glucose-dependent insulinotropic polypeptide, which actually increases, which acts reverse in some way that it decreases some of the side effects that are caused by the GLP-1. So we're going to go systematically about it. So effective GLP-1 is like it's going to give you a increase satiety, it will increase the insulin, and then it will decrease the glucagon, increase the beta cell proliferation, and decrease the beta cell apoptosis. However, when you add the GIP-1 in tandem to it, it also increases the insulin. It increases the glucagon too. It increases the beta cell proliferation and decreases the beta cell apoptosis. But in the gut, it decreases the nausea. And the main action is there was a lot of controversy about like it actually can increase the fat. It will work on increasing the fat storage, but if you use in conjunction with GLP-1, it actually increases the fat metabolism. So it's increased lipid buffering capacity, which leads to decreased triglycerides. So now when you combine these two, you're targeting the most cardiovascular modifying actions, like you're decreasing your triglycerides, increasing your insulin sensitivity. So you have improved diabetes control, improved cholesterol control, and when you lose weight, there is definitely a lower blood pressure. That's hypothetically we are speaking, and we're going to go over the trials which prove that. So some of the warnings, so as all the drugs, nothing is associated without any side effect. So there is a warning that comes with these drugs, which is about thyroid cancer risk. So you have to screen your patients if they already have a increase in incidence of C-cell hyperplasia or tumors, and if there's any personal family history of medullary thyroid carcinoma. That actually was only in animal studies, but it has remained, and there have not been any human studies to debunk that yet. Another one is multiple endocrine neoplasia syndrome, type 2. Some other warnings that come with this. So some of the very, very famous one is pancreatitis. So there's a potential risk of acute pancreatitis that some of the earlier trials have suggested. Then there is also a suggestion that these can lead to kidney problems. So when you are prescribing these medications, you're supposed to track your patient's kidney functions pretty regularly. Then, as we discussed before, these patient medications do cause gastroparesis. So if you have a patient who already has some baseline gastroparesis, they may not be the best candidate to do that because it's only going to delay their gastric emptying and also worsen their gastroparesis symptoms. So food for thought, like marijuana, for example, in the ED, we see it a lot associated with gastroparesis, and a lot of the diabetic patients who have advanced gastroparesis. So it kind of like a dual-edged sword in those cases. Then there were some warnings about suicidal thoughts and behavior, which was there in the early phases. And actually, FDA actively has removed these warnings from these medications, and they have been debunked that they do not cause that side effect. So we don't have to worry about that anymore, which is a very recent development. Then GLP-1s and pregnancy is something that has been the talk of the town lately. So GLP-1 modulates your hypothalamic pituitary ovarian axis activity and also has an anti-inflammatory effect on the ovary and endometrium and improves the insulin sensitivity. So as opposed to a lot of the drugs which adversely affect the fertility, it's actually one of the drug which has shown that it significantly improved fertility, especially in obese women and women with PCOS. It's also thought that metformin is prescribed in PCOS, and GLP-1s kind of by increasing the insulin sensitivity work in the same way. How it exactly does it, still the mechanism of action is not very clear. But is it safe for the fetus? And when should we discontinue that? Is up for discussion. Still, there is no real actual guideline. The manufacturers recommend that the patient should stop it 2 months prior to getting pregnant. And if you find out while you're on it that you're pregnant, to stop it right away, because it can theoretically cause fetal hypoglycemia or delayed fetal weight, decreased fetal growth and restriction, and some skeletal development. And also for when the organogenesis is happening in the first trimester, that's very critical. So stop that drug as soon as you find out you're pregnant. That's the one approach a lot of physicians are going with. And there is some prelim research which is very, very recent that it did not increase any malformations, and they did show that there's a higher risk of preterm delivery and gestational diabetes or hypertensive disorders, and that could be the bias from the subset because of people who are on GLP-1 were already at increased risk of all the pre-delivery gestational diabetes and the hypertensive disorders of pregnancy. There is some suggestion from the studies that GLP-1 is not even detected in the breast milk, so it should not have any adverse effects, but caution is recommended. So next is like, how do you actually do that? So I know there's a lot of different types of physicians on the call today, and the initiation is typically, it begins with a low dose, and then we gradually go over the weeks. Typically, it has to be done by your PCP or an endocrinologist, and the PCP typically likes to follow you up in 4 weeks period in the initial stages where routine. Some of them, there's no like a clear consensus, but most PCPs like to do the blood draws at the four-week use or the 8-week use, depending on the baseline health and the risk of the patient, or the baseline CKD level and the overall health of the patient. And once a maximum target is achieved, then maintenance dose is also actually recommended for the long term. There has been a lot of debate about some endocrinologists believe that once you stop it, you gain all that weight, or if it's purely done for the weight loss. And people who are using it for diabetes should be using for the long-term management. So the good part about that administration is it is an injection, and only recently some of the oral drugs are approved, but there's no big studies that are out to talk about that. But so administration is once weekly. That makes the compliance very easy, and almost to the point that, like, as a ER physician, when I talk to patients in the ER, they all almost always skip telling that they are on these medications. For example, when we treat them for any hypoglycemia or anything, patients you have. So if you are a physician and you are seeing a diabetic patient, please ask them, are you on any injections? Because we are typically ask them about insulin, and that's what they know about. But these once a weekly injections, they forget about them. And individualization of the regimen is something that is highly recommended for the physicians, because dosage regimens are dependent on the care of your patient, their needs, and how they are optimizing their overall health along with that. So this is a sample of titration of Ozempic in a multi-dose pen vial, and it started typically at 0.25 once weekly for 4 weeks, and then it's increased to 0.5, and it goes to up to 30 to 50 units. This is another similar chart for the Zepbound, where on month 1, patients are typically on week 1 to 4, and it's easier for pharmacies to send it for a month supply, and then month 2, they're up titrated. Sometimes if the patient is having great results at, say, a second dose, then they may not even titrate it higher and continue with at that dose itself. The general storage guidelines. So these medications, almost most of them do require storage in the refrigerator, and only certain brands can be kept at the open pens, can be kept at the room temperature. So that makes the travel and the lifestyle of the patient a little bit difficult. So if your patient is like traveling, they may not be able to comply with that, and then there may be adjustment like when they can take that drug. For example, they were supposed to take it from every Sunday. So if they may not be able to do that, then they may have to do it Monday, but it should not be taken like earlier than a week. And you can educate them about like if you missed a dose or how you can do that, but do not refreeze that. So this is a lifestyle nutritional priorities to support the GLP-1 therapy for obesity. When you are initiating a patient on a GLP-1 therapy, it's a very patient-centered approach. It is very important that they complete a baseline nutritional assessment and screening. When we talk about that, what does that mean? It means that do they at baseline eat a protein-rich diet, low carbohydrate diet? Have they adopted any health lifestyle changes? Typically, these medications are only prescribed after the patient has done all the other measures and have some lifestyle modification. Otherwise, insurances you typically don't approve that if there is no demonstration that patient has been on some diet programs. And a lot of insurances have the intake form where they will ask the patient, are you enrolled in some kind of weight loss program in supplement to this? For example, walking with the walkers or Weight Watchers or a lot of the standard programs like or Noom. If patient has failed all those, then insurances are more likely to approve that, because these medications can also be very expensive for the patients and may not be covered, and it will be out of pocket patient cost, and not every patient may be motivated to do that. Then after that, once you start them, there is a management of gastrointestinal side effects. So this is a step where you have to counsel your patient that when you start the medication, you may feel nauseous. You may feel nauseous, especially in the beginning stages, for a very long time, and may not vomit. And if a patient is used to of eating, say, a certain amount of food, say, like 3 servings of rice, and now they're trying to eat the same amount of food, that is not going to happen with these drugs. So if you're eating the same amount of food that you were eating before, then you will have nausea, and some patients may have vomiting that will lead them to the ED. Another side effect that patients experience from these GI side effects is like I have actually seen that lesser than the other ones, and is also less documented in the literature, is the diarrhea. Some patients have runs of diarrhea after starting these medications, and the key is that it's more common in the initial stages, and they have to hydrate themselves. Like for a diarrhea patient, how we typically approach them in the ED is like we talk about the oral hydration. We don't give them the antidiarrheal medication like loperamide too, because that's just going to worsen the symptoms and cause the whole gastroparesis worse. So there's a lot of counseling that needs to go in, and patients may be aware, because if you do not counsel them correctly, they will be setting up for failure. Then, as we spoke about navigation of dietary preferences and intake, now the patient is eating lesser. And so it is important that what they're eating is nutrient rich, and it provides them the basic key nutrients like proteins and vitamins. And you may have to put your patients on some vitamin supplements, like typically after the gastric bypass, which is a different mechanism, but I'm going to analogy that you need to supplement these patients. So a lot of these patients may start losing their hair, their skin may be extra dry, they may feel quite dizzy, and they may not feel uncomfortable. They may feel very uncomfortable about these facts. But if you counsel them before, and there may be a worsening of anemia, so typically my recommendation usually is to people to have some based on your hemoglobin, like have continue to watch the iron and the hemoglobin along with your kidney functions when you are seeing these people, and supplement as needed. Along with that, check their vitamin D levels, and some form of vitamin B complex and water soluble vitamins if they cannot supplement their diet adequately with all the fruits and the other vitamins that are necessary in the diet, because the portions are going to go much lesser as compared to what patient was eating. Then another concern is about preservation of muscle and bone mass. So in initial studies, there was a lot of concern that once you are going to lose the weight, you're going to lose all that muscle and all the lean body mass, which is actually debunking as more and more studies are coming along. However, you have to tell the patients to have some kind of weight training when they're on these medications, because that's gonna only augment the result of these medications, whether you are giving it for your diabetic patient or it's for your obese and overweight patient. Then all these strategies, when you will incorporate, will lead to maximization of weight reduction. And what's the timeline? We're going to talk about it. And obviously, promotion of other supportive lifestyle measures, which include exercise, active lifestyle, proper sleep, good nutrition, no smoking, no alcohol. And alcohol is a big one because as it is, GLP-1s will have a, a tendency to cause pancreatitis. And if you're drinking alcohol on top of that, there is a much higher risk that your patient can develop pancreatitis. It's absolutely not contraindicated to drink alcohol, but they should not consider. So now coming to all that, now that your patient is on GLP-1, when they will land in the ED, what brings to them to the ED? So most of the testing that we do in the ED when these patients come, and typically the presentations range from nausea, vomiting, feeling dizzy, syncope, and some cases gallstones. It is believed that when the K cells release the GIP and also release the GLP-1, there could be a cellular response and apoptosis that could lead to inflammation and the ductal hyperplasia. So we always check the electrolytes for these patients along with the kidney functions, and it is recommended to check the lipase. Uh, However, as I said before, you have to be very comprehensive with your ED patients when they come. A lot and more patients do not even consider it as a regular medication because they think it's once a weekly shot. So if you see a patient who is suddenly feeling dizzy, lightheaded, be sure, to ask that in your history. Otherwise, you may miss it. And increased risk of gallstones. If the patient specifically has a right upper quadrant pain along with nausea, vomiting, and has with or without tenderness, we'll recommend doing an ultrasound in the ED for these patients. The treatment usually is supportive, and there are very rare cases that there is any significant mortality from these pancreatitis. Only 19 deaths have been reported from deaths. This the data is from UK. It's actually not from United States. Then there's another concern about recurrent acute pancreatitis. All the studies have shown that overall risk of pancreatitis in GLP-1 versus the non-GLP-1 is actually lower. And that initially there were a lot of concern about it, but the recurrent acute pancreatitis is only maybe 4%. Actually, there's not a actual frequency they have given it, but overall life risk, I'm going to show you a slide which suggests that is much lower than if your patient is not on GLP. So what are our treatment? If you have acute pancreatitis, you're suspecting, we're going to do the right amount of labs, supportive care, we'll rule out gallstones, we'll do the hydration and pain control. Most of these patients end up going home. And this is the guidelines from the Kidney Foundation. They actually recommend the GLP-1 for type 2 diabetes and CKD who have not reached their goals. So these don't be discouraged if you see a patient whose creatinine has been bumped a little bit because they were not hydrating and they are on GLP-1. It should not be a knee-jerk response to just take these patients off that unless their lipase is through the roof and they are really have other derangements like elevated LFTs, and it's case by case basis. So, and this was about the presentation in the ED. Similarly, in the ED, we also end up in cases where we have to do procedural sedation on these patients or intubate these patients who are on GLP-1. And that led me to think that what are our recommendations, like how long you should be an NPO. Technically, when we intubate somebody in the ED, there is actually all emergent intubation, and we don't think about the NPO status at that time because it's an emergent intubation. However, for the procedural sedation, we do consider it, and if we can wait, we do wait for the appropriate NPO status. Classically, there is not one set guideline that I found, and different procedures, and definitely not in the ED. There has been any guidelines that are out, but this I thought was very interesting that patients, it is important to think like how the anesthesiologist will think about the patient. What is their preoperative risk stratification, if they have a lot of comorbidities, if they're on any other drugs like opioids, which also cause delayed gastric emptying, increased your delay your enteral time, PPIs, or any recreation drugs. Then if when you're doing the procedure, maybe it's recommended that it should be withheld for 3 half-lives. 3 half-lives would be very difficult to achieve because most of them actually have a pretty long half-life. If you think about that, it will be at least 3 weeks. So if the patient is not high risk, they don't really bear a lot of sequence on like what you should do. But if they're on a high risk, then you do have to do extra testing, and you may not be able to do that procedural sedation in the ED, and then you may consider getting anesthesia involved and other people involved who should be doing the procedure. Similarly, for colonoscopy, they have found that you can safely discontinue the GLP-1 only 24-hour liquid diet, and you can continue to do that. But if there's a high-risk patient, it's a personalized approach. There's no consistent guidelines. Similarly, for the cardiology procedures, there's a up and down side about it, like about peri-procedural risk. Like one thing is to delay about delayed gastric emptying and pulmonary aspiration. Another is that these patients also tend to have worsened peri-procedural glycemic control, and which may not be feasible. So these guidelines are up and coming, and for now we are managing every patient on individual basis, and also it's up to the anesthesiologist. So these are some of the landmark trials that came for weight loss and obesity. This was the STEP program for semaglutide. It had 8 trials, which showed dramatic weight loss in overweight obesity with step 1, showing more than 15% reduction in the weight over 68 weeks. If you think about it, it's not as quick. It's over an year, but the change is really in patients who have not been able to shed any weight and actually have been on the other side, just going south, have really made a difference. Then tirzepatide was with SURMOUNT program, which is which evaluated dual GIP and GLP-1 receptor with over 20% weight reduction, where that was rivaling the bariatric surgery because that's pretty rapid. And for weight loss, a lot of physicians actually do recommend tirzepatide over the other drugs which are in the market. SELECT trial was considered one of the landmark trials in this field, which showed the 20% reduction in major adverse cardiovascular events in obesity and also the cardiovascular disease, which actually shifted the needle even towards the huff puff. So in step 1, they demonstrated that 2.4 milligram of semaglutide was highly effective when it was combined with lifestyle intervention for weight management. And then they did a step huff puff where they showed that semaglutide actually improved symptoms and physical limitations and exercise function in patients with obesity-related heart failure. So a lot of these huff puff patients, it's like a chicken and egg situation, but obesity is like a very, very important factor when dealing with the huff puff patients because usually they don't have ischemia, they have a preserved ejection fraction, but they are not very functional. And it is believed like obesity plus all those symptoms actually is equivalent to huff puff in many definitions, since there's not a consistent definition until recently. Then step 2 focused on both overweight and obesity with type 2 diabetes, which showed significant weight reduction of 9.6%. And this is the STEP Huff Puff trial. I just want to show you like what was your inclusion and the exclusion criteria to kind of take a peek look at it. So they included all the patients who had a NYHA class 2 to 4. They had a BMI more than 30 and LVF more than 45, but they excluded anybody with diabetes or who had gain of more than 50 kg, 5 kilos in 90 days of the screening. And There was primary outcome. It showed a significant reduction in their even pro-BNP in a 6-minute walk test, in their body weight percentage. If you look at it, it's 13% versus when they were given placebo of 6%. So it definitely improves your cardiometabolic health with very little side effects like nausea and diarrhea. This is an overview of the SELECT trial where the primary endpoint was death from cardiovascular causes, and it was 6.5% versus 8%. So there's much lower mortality with these drugs in this population. In the interest of time, I'm just gonna show you some slides which shows that how much research and data has gone into these drugs to establish their safety and efficacy in the market. So if you look at this baseline A1C, it's 8.1, 8.1, 8.3 in these trials, which is very similar in these series, and how the number of patients that has been included in here. Then SUSTAIN series was a set of 15 phase 3 clinical trials. Similarly, that how we discussed with the STEP. This was further it assessed whether it has a superior efficacy in controlling their hemoglobin A1C, which physicians routinely use to track the improvement in their diabetic care. And the MACE events were noted in SUSTAIN 6. Then it showed a reduction in both A1C and the body weight in SUSTAIN 7. And it also showed when you add the SGLT2 therapy, there's a better profile in SUSTAIN 6. So there are more trials coming, like a FLOW trial, which is going on to study the kidney failure risk with type 2 diabetes and chronic kidney disease. And then further trials are STEP, HUPFUP, and SUMMIT. There's another trials which are in the phases as light through liraglutide with exercise. This slide shows kind of like a summary how they improve your cardiometabolic health and decrease the risk of stroke, kidney failure, heart failure, and all the end organ damages that happen with these essentially metabolic syndrome type of causes. So where we stand with the guidelines, recently WHO recommended that in adults living with obesity, GLP-1 or dual GIP and GLP-1 dual agonists may be used as a long-term treatment for obesity. This is a recommendation in the wake that obesity is a epidemic, and then they also American Association of Diabetes Association also recommend in type 2 diabetes both these medications. And recently AHA guidelines incorporated that with life essentials of 8, which is good sleep, good food, exercise, tracking your blood sugar, weight management, and then adequate hydration, blood pressure control, and no smoking. So that was in the recent guidelines, along with the Kidney Foundation, which suggested that for the improved CKD outcomes. So it definitely can prevent potentially patients from dialysis and decrease that incidence. So there are some perspectives here, given, these medications are once weekly. I am, personally as an ER physician, we get a lot of patients who also have mental health disease. They don't take their medication. There's no explanation, or is a cost of medications. There are a lot of compliance issues. There are follow-up needs. It definitely needs follow-up because these are newer drugs, but as more and more the safety is established, it may be a very reasonable way to treat the patients who have mental health disease and have all these diseases that they cannot, and they're just gaining weight, they have worsening obesity, worsening kidney disease, and it makes them very complex patient, along with the patients who are in incarceration, rather than giving them insulin. So that's a food for thought, like that's a further down. So what's your verdict after hearing my thoughts?
Thank you, Dr. Garg. There are 2 or 3 comments or questions here, I think.
Oh, let me see. So, Ozempic syndrome. Okay, so there's a lot in the social media about what is this Ozempic syndrome. So it's subjective. So if you open your social media, like, there will be like everywhere people are talking about the thin face, nausea, vomiting, um, and multiple side effects that we talked about. And if you go on dermatology sites, they're talking about hair loss. Um, so these are all the changes that come from rapid weight loss. There is thought that the patients will just have flaps of panis, and like, this fat will go away from there, but they will not be toning. So or and with all these side effects. So, but more and more studies say if you counsel your patient adequately, tell them how to walk with these weight training and toning with the weight loss, they tend not to happen as much. Then I have another one, 3 2 patients who are completely resistant to weight loss. What does and what else? Okay, so you can give them a dual agonist. If GLP-1, I think Monjaro is dual, I feel like. Let me just double check. You can try switching the medication, like Zepbound, for example, has very good results and better tolerance in the patients. But as long as their glucose is getting better, are they on max dose? I am not sure, but you can try switching the medication. Do the trials include South Asian? Yes, there have these trials. That's the beauty, and that's why I wanted to show you. They have been in China, they have been in UK, they have been in South Asians. These are really international trials. These are phase 3 clinical trials, which also involve after marketing these drugs. And by the way, I want to talk about South Asians. South Asians, the cutoff for obesity and overweight is much lower. For example, in South Asian women with BMI more than 25 is overweight, but Caucasian women is overweight only after BMI of 27. So we are at increased risk, and if your patient is South Asian, they definitely need a chance, and they should be counseled about what to do. Uh, but again, these patients need follow up and ownership. So if you can't follow these patients, I won't recommend it. Are GLP-1 good for type 1? There is no literature right now. Type 1 is totally a different pathophysiology. So I have not seen that trials, and I would not recommend that. What about pediatric patients? There is not a trial yet. I know they have been starting some trials in pediatric, like teenagers with obesity, like when there is a pubertal transition, I should say post-pubertal patients that I have seen. Uh, who are normal weight? I think I answered that question a little bit. It depends on your race. It changes, like, and there are different associations. Your last slide, what do you meant? Interested. So I don't have a private practice. I'm a ear physician, and I believe because I am the end receiver of all these cardiovascular changes, and I see young people having heart attacks, strokes, and I see them in the bad shape. That's why I am particularly motivated, and I'm also a heart failure researcher. So I'm very, very excited because after GDMT, if we add this to the GLP-1 to the patients, I think it can cause profound outcome improvements. What I meant by that verdict is like now you choose, because everybody from social media to the literature, there are a lot of things that are coming out. Oh, it's just like bad. And I also talk to physicians, and I get all the different types of opinions. But honestly, I have not seen increased lipase yet with the pancreatitis. Like it's symptomatic, like it will look like that patient may have nausea, vomiting, some epigastric pain, but it's just like their body is adjusting to all those changes. And they are responding to that. But I have not seen somebody who's very sick from that. And most patients some of the patients, I had the pleasure to see them again and they were on it, or I followed them to see. And I'm personally very interested in that research further on.
There are
These
two
drugs
more
are,
questions and we end it, Dr. Garg.
sorry,
Just
there are
end
a lot
it.
of questions I'm trying to
Yes,
catch
yes, yes.
up.
Just end it with the last question, up to last question. So finish answering. I think there are 2 or 3 more, I think, to go through.
2, 3, 1 second. So
I
we
think,
have recommendation.
yeah, it
When
says when
patient,
to end, like when people reach the normal goal weight, what would you do with
so you titrate it down, like instead
the
of once
dosing? Yeah,
weekly,
yeah. Okay.
so you can keep them on that dose where they ended. So there are various strategies. You can choose your strategy, but you can keep on that dose and ask them to go bi-weekly, then ask them to go, don't like go from all to none. Go slow,
Mm.
like you do with the Metrol dose pack, right? You go down every week. So now you increase your weeks. So say your patient was on 5 milligram of Zepbound when they reach their weight gain uh, goal. So you keep them on 5 milligram every 2 weeks, then ask the patient to continue to watch their weight. If they are able to continue their activities and do that, extend it to 1 month, then go down to once 3 months. They call it micro dosing. And sometimes patients may just be kept like once in 3 months. And it's like it also has actually, I didn't talk about it, but it has scope of treating drug addiction too, because obesity is sometimes we use food as a contract for depression and all that stuff, stress management. So you can do the titration. You can choose. It's a shared decision making you can do with your patient. You can ask your patient, if I take you off the medication, how much you can manage your food and how would you like to go down. Some patient will be like, no, but don't go cold turkey. That would be my advice. Otherwise everything can come back and they can rebound. It's like an alcoholic, or I'm not saying like all the obese or diabetics are alcoholic, but food is medicine at the end of the day. Thank you, everyone.
Thank you. I really appreciate Dr. Garg. It's an amazing presentation. And GLP topic never, you have so many things to talk about it. We had it
Yeah.
last month, but people have so many questions here again. And
I
but
will
do
write
you literally how often you see somebody with coming in with any complications with GLP-1 in ER?
a lot. A
A
lot
lot?
in the
Huh.
sense, I will tell you why. And it's not truly a complication. Like patients
Mm-hmm.
who get, they have nausea. They're not appropriately counseled.
Mm-hmm.
And they're like, I'm feeling nauseous. I'm not feeling great.
Mm-hmm.
It's kind of like what you remember like many, many years ago when people were given metformin and they're living at a certain glucose and now their energy is
Yeah,
all the way
metformin
down.
was very nausea producing in those days. Now I don't see as many nausea.
Exactly. So I think patients are being counseled better. It's not like
Yeah,
and
yeah,
also people are less paranoid about it because their uncle is on metformin, their aunt is on metformin, so they know about it.
yeah.
This is new, so it's a new drug on the market. You're hyper vigilant. Your physician is
That
hyper.
is true. That is true.
So everybody, anything that happens, like patients come to the ER. So we see
Yeah.
variety of presentations.
Okay, well, I'm going to end it here because we can keep on talking for a while. It's 10 minutes beyond, and I really appreciate the audience more than anybody else. Dr. Upadhyay was excellent, so was Dr. Pia, and God forbid anybody gets into the situation. And Dr. Garg, thank you for stepping up at the last minute for moderation also. And I appreciate all the speakers and I hope to see you at the convention. Amit will not be here right now, but he asked me to just throw a pitch. Convention tickets are going to be A to Z package will be available May 1st, I think. And right now is the one that you want to buy with the hotel and other everything is like complete package is there. So wait till May 1st if you want to wait for that. But if you want to get the best tickets, go for the packages. And hope to see you guys. And we have good CMEs planned there, okay?
Thank you. Thank you for having me.
Thank you.
Thank you. Bye guys. Thank you again. Thank you. Thank you.